Welcome to #Wednesdays Weekly, a weekly information session held in collaboration with the voluntary sector and public sector partners. This week, the host is Julian Cohen from Turning Point. Pass over to you, Julian.
Hi there, everyone. So my name's, shall I go straight into share screen?
You want
I suppose my name's Julian Cohen, Community Development Worker for Turning Point. So I'll go straight into the share screen. I just clicked on it, it's not share.
Don't worry.
Okay, so I've done this, had a look at how COVID-19 has affected the service particularly, and also our client group. Right, so with regard to it, looking at it, we're looking around how COVID-19 seemed to just appear from nowhere, which for our client group, I suppose anything that just happens unpredictable can be quite anxiety forming. I suppose really they didn't know what to expect, so it's around what was expected from us, how we were to react, and specifically the clients, how they would respond. So the response from the clients, whether it was a positive or negative response, and again it was difficult for the workers because there was so many uncertainties at the time, and that's to look at things like the substance use. Would it increase? Would it decrease? Would there be problems with supply? We're then looking around sort of prescribing and looking at things like risks. How would we identify risks? What were we going to do with them? And how we're going to put in new innovative harm reduction initiatives. And then I suppose really we need to look at post-pandemic, looking at building resiliency for clients, the asset-based nurture development model, and also how we can increase self-efficacy for the clients. So that's what we're going to look at within the session. Looking at the background before the pandemic arrived, we look at Rochdale primarily. We're looking at the highest risk, and what's probably going to affect most is the older clients that have been in long-term treatment. Some of those clients may be long-term substitute prescribed methadone, buprenorphine, some of the medications used for people that have been using street heroin. Again, I think the background is we might have a cohort of clients that have a range of multiple disadvantages. With that presents COVID-19 and possibly a healthcare system becoming quite fractured suddenly, and those issues around anxieties due to that. We may be looking at a client group with pre-existing health conditions and comorbidities as well, which means that they may face actually even more difficulties than most. I think we can look at health inequality generally being something in a lot of the Lancashire towns, but specifically Rochdale. So we may have higher levels of smoking than the national average. Just general population, if we look at the LAPES, the alcohol profile indicators, the harm from alcohol on the general population and individuals is also higher than the benchmark of the national average. Things like hospital admissions, things like accidents due to alcohol, and a whole range of health conditions due to alcohol. So Rochdale is higher up there than the benchmark of the rest of the country. The thing as well, off licenses were considered as essential shops during the lockdown. I understand why, the fact that some of the off licenses also sell food, but I think that a big part of it was suddenly even things like bargain booze that doesn't sell food was also considered as an essential shop, even at the beginning. Housing inequality. So also as well, we found that suddenly Greater Manchester Combined Authority realised that they had to suddenly put a lot of money into the area of housing for people that were living on the streets. And also food and fuel poverty, which was endemic anyway before the pandemic came. So we look at the COVID-19 and we look at the actual virus. It looks quite scary, doesn't it? Whenever they've showed pictures of the virus, it's almost like apocalyptic, with lots of spikes on it, and it's usually got lots of colours around it. So we see that as the first point. There was a whole lot of stuff in the media as well about this unknown virus. It was unknown, but it was accentuated by the media, by the fact that it was suddenly coming from China, and quite scary. So think about how that would affect our clients. So there was two ways. Was it going to be the apocalypse? Was it going to be like the picture at the top, or was it going to be something that was calm and serene? And I think for the client group that we work with, suddenly we always almost think that it's always going to be the worst case scenario. But I know in the early conversations that I had with a lot of clients is they were actually quite resilient about the lockdown. Some of them, they were very much about, right, I'm definitely going to stay at home. I'm going to look after myself. I need to look after my health more than most. And they were very around the fact that things were going to change. There was going to be no one-to-one support, one-to-one contacts. Actually phoning them was something that some of them embraced quite quickly and said, actually, it's quite a positive thing. It means I can stay at home. I've got more time to spend at home. I can concentrate on things. I can look after myself. And actually, it's saving me money by not having to go to a service. And there's a lot that can actually be done on the phone. But then you've got the other case where you may have clients that are not, haven't got good support within the community, good family support. And the only person they might actually see is when they come to a service like ours. And to them, it was really difficult from day one, and also around how was the mental health, the physical health support needs when everything at first seemed to be falling apart. So I think for some people it was the top probably picture, and for others it's or the bottom, but for majority it was a bit in between, and people might move between different thoughts along the way and cycles. So I know Turning Point and Raw, we responded in a very person-centered way, working to look at how individuals might face this sort of pandemic and what they were feeling. So what were the challenges for COVID-19? The original one from a service point of view, and it came from Public Health England, that the pharmacy provision may fall apart. So for people on substitute prescribing, if people are on heroin, they may be getting methadone from us or something called Subutex as a replacement to use illicit drugs on the street. Some of those clients may have been on what we call supervised consumption of that drug within a pharmacy. And with the pharmacies falling apart, the initial worry was that supervision might not be able to be continued, particularly places like Rochdale Oldham, where there were very small pharmacy chains, possibly some of them 1 or 2 man bands in small areas. Would they be able to carry on even giving the methadone to people supervised? So we had to look around, perhaps giving people that had been on supervised methadone, giving them bigger amounts in one go for the whole week. And that's a huge challenge for people that have been on a long-term prescribing regime, and it presents extra risk. We didn't know what was going to happen to healthcare services generally, to hospital departments, and I don't think the healthcare systems, they were on a daily basis looking around how they were going to do things. Nightingale ward, would hospitals still be open? Would people be able to go to A&E? Nobody really knew at the very beginning, so that was a key area that was a worry. What was going to happen to people on the streets? So people had previously been on a bed for a night provision in churches, sharing pull-up beds. That couldn't continue with COVID-19. So GMCA looked around getting those people quickly into hotels, which then meant we as a service had to react proactively to make sure that those people in the hotels were going to be safe. And we did that really, really quickly with our management team very, very early on. Intoxicated folk, are they going to be able to social distance? How would that be managed within services, like coming to our service? Again, we had to look around that very early on. Alcohol, if people are drinking, will they be able to continue to drink if they're drinking every day? And they need to drink in order to avoid fits and seizures. Would they run out? Would they be too ill to go out and get it if they have to at least socially isolate? So loads of questions. Food provision. So we know people that are using drugs, people using alcohol, need to keep up with the nutrition and specific vitamins. How is that going to continue? Smoking restricted areas, if they were in bed for a night hotel accommodation, again, that could present risks. The other challenges is we're asking clients, people we work with around to, like ourselves now on this, around digital inclusion. Are they fully involved with the digital world? Do they have telephones? Do they keep the telephones for review appointments and things like that? So loads of questions there. How are they going to store medication if they're given full weeks worth of medication, if they're living in areas where they're sharing with others? Big area that we looked at as well with the management team, we're looking very closely at, was preventing overdose, looking around the risk of people dying. I think that was the big thing. I think at first we thought, would the client group that we work with COVID-19, are they going to be more susceptible to catching COVID-19? If they do, are they more likely to have complications of COVID-19? And that was a big area of worry, but also the fact they might overdose, or they might, around as well, mental health decline. So around suicide prevention, stuff like that, we need to look at that. Will clients be more risky? Will they take more risks? Will they be, again, going back to the apocalyptic scene, the pandemic, the virus that suddenly comes from China? Are they going to think, well, this is I'm going to be so at risk? Does it really matter now? Do I need to look after myself? And that can sometimes happen. As well, the supply of drugs is a big area. Would it be drought? Would the market be flooded? Would there be more dangerous type of drugs coming onto the market? We didn't know, because it's the first pandemic and first thing that's ever happened like that. There have been previous things like the banking crisis and crash then and things, and it does tend to affect things in terms of supply of drugs. We look at alcohol specifically, different types of drinkers, affecting young, rich, old and poor. So that's another challenge. What was the response? Well, the response was absolutely fantastic in Rochdale. Rochdale's got a fantastic history anyway of the community working and acting to support the most vulnerable, going back to the days of the Rochdale cooperative movement. And there's still that ethos, the ethos from action together, from grassroots gathering. I suppose everything's there already in the community. It has a whole range of positive things already that are already helping our client group and people that have needs. So the community was acting really, really quickly to identify need. Rochdale Council had their crisis lines, they had their crisis intervention points. They were helping people straight away that had to self-isolate, mobilising to get food to people in need. Clients, I suppose, we helped and supported them to adapt to this change. And don't forget, it was a change to our services and workers. And we have to remember as well, workers within services like this may also have health conditions as well, that also mean that they had to adapt to the change. So there's a lot of change. I suppose really the clients, sometimes they didn't have a choice. And sometimes with the clients we work with, when they don't have choice, they actually do very, very well. They can be very resilient at living on the streets. They may have a dog, they may be living in tents, they may be doing all sorts to survive. So actually they can be quite resilient. The prescribing change was the response as well. And that took a lot of in-depth work with clinicians, with our healthcare teams, to see how they could look at who was safe to have more drugs in their possession, depending where they were living and what they were doing, and also depending on previous risks. So there was a whole range of, a lot of work for the workers to do to sort of change prescriptions to say that person needs to stay on supervised consumption, but actually some of the others can actually be given more drugs and more responsibility with that. We had our own detox unit, which is really, some of the detox units closed, but our own detox unit stayed open for emergencies. We initiated extensive harm reduction and assertive outreach immediately. Overdose prevention training was rolled out massively to partner agencies, and also essential needs for partner agencies. So we got the lock boxes, overdose prevention kits, where people needed paraphernalia, so injecting equipment. So we have to look around again, the fact that people that may have smoked drugs might start injecting them because there's less waste if they're injecting. If there's less drugs on the market, they may want to inject rather than smoke it. Smoking drugs is wasteful, particularly if it's heroin. We supported partner agencies around their own clinical and safety procedures. So sometimes, again, the partner agencies, for them, everything was suddenly, we may have more risks of overdose. We may have risks of more methadone on the premises. So we did a lot of work with the partner agencies around clinical and safety procedures, and also cascading early warning systems of harmful drugs and any acquired community infections. So a lot of work there comes through from Michael Linnell with early warning system that we get, but it's around cascading that, and that's something that's ongoing all the time. Our safeguarding lead straight away was very instrumental in looking at things around a proactive response to anticipated increases in DV cases. So domestic violence, we can look around the pandemic, people being at home with other people more that they might not normally be with, a whole range of more alcohol being consumed, people getting touchy and irritated with each other. So the safeguarding lead did a lot of work of cascading information to the teams and to partner agencies. Again, we were looking at supporting clients around digital inclusion, around accessing support, not just with us, but with also other services within the community, and ensuring that they had telephone access. A service as ourselves by RAW, we were supported by our own Turning Point service, and rapidly with enough PPE so that we could use safe working from the service itself. So that was quite a key part of making sure that where necessary we could be here. Let me just get rid of that before it shuts it down. So that we could actually be here for the people that need, and that was initiated quickly. So what happened with the drug supply? Was it going to be a drought? Was it going to be abundance? Previous issues that have occurred in the country usually looks at drought of drug supply or quality of drug supply. Abundance of drug supply, when does that happen? More by fluke than anything else. But with this pandemic, neither of those two actually happened. Things were fairly stable. If anything, the drug that probably got most affected was heroin, due to the fact Afghanistan, Pakistan, the main producers of the heroin in this country, tended to be a little bit less, but not massively. So what we do know is, as well, with the COVID-19 and the police being on the road a lot more, and you can actually see it from areas, there was quite a few drug busts. And certainly, I think at the beginning, the drug dealers themselves probably realised that driving around dealing drugs was not going to be as easy as it had been pre-pandemic. So there definitely was more busts of drug supply, but in actual real terms, there wasn't a massive difference. It may change as we go on. I've been looking at the evidence, but there isn't a great deal of between the two, somewhere in the middle. So the drug supply for COVID-19, we know where heroin dropped off, there was an increase in benzodiazepines. So things like Valium, but also this is where the biggest risks occurred. Quite a lot of fake benzodiazepines, Valium. Some of them marked as Valium weren't Valium, there was something stronger, like Ativan or something else. Increased use of gabapentinoids, so things like gabapentin and pregabalin. they've been hovering around on the market for quite a long period, and they do produce quite a lot more risks. The heroin supply stayed and remained almost stable, albeit mixed with other stuff, and possibly becoming weaker. We do know there was less use of club drugs with the younger cohort, so the fact the festivals didn't go ahead, we know there were less drugs there. Where we are possibly in places like Rochdale was increases in use of non-dependent drugs in the younger clients, so things like your nitrous oxide, the little metal canisters and stuff that you see discarded in countryside areas. You've got quite a lot of areas of countryside where people park up and use drugs, the younger folk, and cannabis as well. And then you've got the associated risks of drug use, drug driving, so drunk in charge of vehicles and stuff. So we do know that did happen, and we did do some quite good partnership work with the police that work within those countryside areas to look at that. Again, reducing the risk and advice and information to people that, if we're not going to stop that type of drug use, but around if they don't drive after it. Increase in use of cheaper and longer acting drugs, and that's something that we might see after the pandemic. Things like the amphetamines and crystal methamphetamine becoming more of a problematic drug because it's cheaper and it's long acting. The bed for a night provision presented the risks of users mixing with other users, so complex folk mixing with other people, and that can always create extra risks. We did see increased use of spice when it became available. So we know the precursor chemicals for producing spice tend to come from China, but what it is quite easy to use any herbal matter and spray it with anything you want, which can cause extra issues and problems. So things like car alloy cleaner and stuff like that, spice can actually end up being not what it should be. Possible increase in street methadone supply as a result of less on-site pharmacy consumption. So that was always going to be a risk, and may continue to be a risk, that you get more methadone supply due to on-site pharmacy consumption. A few slides here just to get an idea. If you've not actually physically seen the drug, heroin predominantly in this country comes as a very light brown powder. It's very, very rare that you see things like the extra strong China white. It's very easy to mix heroin with pure heroin with anything just to adulterate it, and that's more likely to happen at times of pandemic. Powdered cocaine. We saw less use of cocaine during this pandemic because less people are going out, less people were partying, but it's only slightly down the cocaine in terms of use. Cannabis, slight increase. I'm not sure about Rochdale, but generally we're looking at European markets, more homegrown use of cannabis with people being at home. So people having more time to get the seeds, acquire the seeds by post, and to grow at home. But I'm not sure about Rochdale. There's nothing come through around that. These are the ones that we do know have presented problems. Most of the benzodiazepines we're looking at Valium, usually called blueies or blues because they're blue. Your 10 milligram diazepam there, usually a pale blue, but the ones that have been seen on the market have been quite a strong blue, and some of those have been fakes. We've had a few, I'm not sure about Rochdale and Oldham, but certainly I know of Manchester where there have been fatal overdoses. So your benzodiazepines slow the central nervous system down, slow brain activity down, slow breathing rate, and ultimately can lead to death. So if people also mix them with things like methadone, with heroin, with alcohol, they even increase the risk of death. So, but there is a lot of fakes out there on the market. Crack cocaine, expensive drug. Usually a small rock would cost, and which is a tiny small amount, would cost about 10p. 10 quid. So it's a really, really expensive drug. The likelihood during the pandemic is that it's gone down. Sex working will have reduced. A lot of crack cocaine is associated within the sex trade market itself. So the crack cocaine will have reduced. And the patterns are overall decline in drug use in Europe during pandemic. So it's a slight decline, less MDMA, ecstasy, cannabis nitrous oxide has increased locally, more home cultivation of cannabis, increase in amphetamine use in the Nordic countries, definitely disruption of supply of raw ingredients for new psychoactive substances like spice, so the adulteration may occur. We've had clients tell us that the strength and purity of local Rochdale heroin is lower than pre-existing COVID-19 rates. We know increased use of depressant substances to balance out low-strength heroin will occur. So black can lagers, which is the high-strength lagers, white ciders, pregabalin, and benzos. 50% of people identified trans-European COVID survey stated it was harder to actually obtain illicit drugs. So why have people changed their drug use? Loss of income, reduced availability to obtain or to go out and get drugs, less opportunity to use drugs, living arrangements mean it's harder to use. So people being at home, perhaps younger people with the parents where they might go out more and couldn't do, people more living together. I suppose if it's communal living in the bed for a night provision, that could mean that some people do actually start to use more and use more riskily, being more risky. Some people have actually, and this is a big one, have actually started to, and I think it's a positive thing to look for the future, is they've started to look overall at the health. We see on TV a whole lot of the time where people are saying, actually, we need to start perhaps giving up smoking. And we know that more people have given up smoking than ever before. So it might be the same with drug and alcohol. More people start to actually look at that. So a lot more health awareness issues around COVID-19, making them think about themselves. Worried about the future and financial uncertainty. So actually, I'm going to keep my money and not spend it on drugs. And we've seen more people wanting to enter an opiate substitute therapy program. So we've had more referrals from people saying, actually, I wouldn't, I do want to actually start treatment and get on a script. Just a quick slide here around people might start injecting more during COVID, because particularly heroin, it is it's less, the drug's less wasteful if you directly inject it. Smoking heroin is wasteful if it's smoked on foil. A lot of the drug will go out into the atmosphere. Oral tablets, most oral, and then immune. So I suppose really for us the biggest risks is injecting as a drug. Quick look at alcohol. We have the drinkers that we will see no or lower risk, increasing risk, and higher risk and dependent. And really it's the high risk dependent drinkers that, or increasing risk drinkers that COVID could present an issue, particularly if suddenly for the first time somebody may have a 12-week period where they're actually at home. And we know that we've seen, or speaking to somebody doing assessments, he's seeing a lot more people that haven't really got a drink problem, but to them they have got a drink problem because they've started drinking more. And those people might just need a bit of advice and information. And actually what people are realizing is a lot of time on the hands is presenting an issue, and they need to actually perhaps look at lifestyle balance to increase doing other stuff so that they don't suddenly realize they've got a drinking problem. The effects of alcohol, quite scary, because a lot of people have not really thought around alcohol, around how much short-term and long-term harm it can do. I'm going to do these two slides quickly because alcohol is one of those that it's very normalized. It's the way it's sold, the way it's marketed. It goes through periods where one drink's popular, Prosecco, then Prosecco's not as popular, and then gin's popular. But what a lot of people don't realize is the amount of damage and harm alcohol can actually cause. And that's just a quick go. The next slide really does show it. There's not one part of the body that alcohol doesn't harm. So it's quite a good slide to look just to see actually there's a whole range of things from all the way to alcohol dementias, problems with the lungs. So 2% via the lungs, it can actually cause problems. Liver, there's a whole range of different areas that it can cause. It's a training session within itself, that, so I don't want to do too much on that. We need to think about as well that we're doing a lot of work with fetal alcohol spectrum disorder and fetal alcohol syndrome. So we may find that suddenly with people not being involved in healthcare services or thinking about contraception or a whole range of issues that they need to look around alcohol and pregnancy, which we're doing a lot of work, but the COVID-19 suddenly could have presented with new issues. And we need to be looking around the fetal alcohol syndrome. Again, it's a training session in itself, but it's around making sure that we were giving the right information to anyone identified at risk. The fetal alcohol spectrum and syndrome can produce a whole range of learning difficulties, problem with language, boundaries, short-term memory, a whole range of issues, which again, we could cover on another. The social impact. So I think the big one that screamed out was the domestic abuse. The other areas that we're looking, financial problems, family breakup. Anecdotally, we know that a lot of people have found difficulties in relationships, and I think those sorts of things might mean a cycle of being depressed, anxious, and drinking more, and a cycle arranged. But the domestic abuse one was the one that we did a lot of work with. So what happened with alcohol during COVID? Well, there's mixed again, a bit like the substance misuse. We know that 1 in 5 people, 21%, are drinking more of the general population who drink. But then we're looking at counterbalancing that. 1 in 3 who drink have reduced or have even stopped. So before COVID, there was a bit of a movement from for people to be abstinent or want to not drink alcohol. Club soda is one of those sort of movements where people have started getting together saying, actually, we can enjoy life, we can do a whole range of things without drinking alcohol. And that continued to happen during COVID. Some people actually used it as an opportunity to look at how they do things, not being with the friends, but also in the supermarket, not falling for the last style drink offers or whatever happened. I know Tesco near me, they had it very cleverly arrowed out, and then at the very end you ended up in the drink aisle, and I thought that's a bit clever. They could have made the last aisle not the drink aisle. So there's a whole lot of subtle things that supermarkets do to pull people in, and of course alcohol is a very, very addictive substance. So of the population, 8.6 million adults drink more frequently, but 14 million adults are drinking less often. And boredom indicated for a reason for those increasing drinking. And I suppose really you have to look at sort of other aspects of people's lives, and it happens where people end up in retirement. Suddenly retirement comes, I suppose it's the same thing, and then suddenly they're at home with a partner that they've not seen as much during the day, and then suddenly alcohol becomes a big changes, big part of people's lives. So that can happen as well. So the whole range of different things, but those are patterns. People were doing effective change, so taking and having drink-free days, 14% of people said they did that. Purchasing awareness, not falling for the offers. Abstinence, 6% just went for straight abstinence. Seeking online advice, so contact to us, it could be for just early intervention stuff. Some people attended remote support groups like Alcoholics Anonymous, mobilised quickly and did mutual aid online via Zoom. Remote counselling And also some people have started using apps on their smartphone to monitor drinking, which are really, really effective. And that's something I think we have a team upstairs that do workshops and encourage clients themselves to take control of their own journey. So using apps is going to be certainly a way forward of looking at drinking, monitoring amount drunk, on days drunk, how many units are drunk. So there's a whole lot of support that we can be given to clients, and the clients can take themselves. The area that we looked at was harm reduction. We kept our needle exchange open. The pharmacies within Rochdale were still operating some of the needle exchanges. We could rapidly mobile and get provisions out to people if needed. The fixed base, as I say, was open, and our turning point were really quick to get us PPE. We're starting a new click and collect service, so clients that have, again, we want to support digital inclusion, which is really important, but we've got a new click and collect program, so if they have got a smartphone, or if they can access a computer anywhere, they can go on it, look what they can actually, what type of, so we will do needles, we'll do swabs, we'll do cups, all the paraphernalia that they need for injecting, condoms, we can get sent to the house rapidly as well. And we have our assertive outreach and harm reduction team as well in Rochdale that can also support that. Within our base needle exchange, it's a great opportunity for change. We can engage people. We're one of the only services to continue with BBV screening, bloodborne virus screening. We kept that going. Overdose prevention, health checks can be done, and it's a foundation. So we kept some of that going, albeit limited, and by appointment we did that. Our clinical team kept prescribing. We made sure that new clients, if needed, would be assessed quickly. Some of it be doing on the phone. If they needed to come in and do a urine screen to evidence what drugs were in the system and how we were going to prescribe, we continue to do that. And people could come to the service, see us, and get a script within a day. So a lot of training, and we need to around opiate overdose, because that was where the risks we looked at. So overdose would be respiratory failure, bluish tinge to lips and other extremities, heavy laboured breathing, death rattle unresponsive. So we did that training quickly, and from that we have something called Naloxone, which is an injectable drug into muscle, which is the antidote to heroin. So we got those kits with our services. We've given out already over 1,000 kits within Rochdale and Oldham, but we reviewed about who had the kits, where else we needed to get them, and we really rolled out remote training very, very quickly. We also, and it's more expensive, but it's a drug that can be sprayed up the nose. So it's a nasal administration spray. And we went around Rochdale and Oldham when we got those drugs out. So they're easier to use, they're not injectable, but that will take some out of an overdose situation. And we rapidly got those out there into the community as was needed. A little bit around infections. We're aware of the infections, and we also were making sure that the clients were aware that if there was any infections in the community, that they was aware of the risks and what to look out for, because that's an important part of harm reduction, is making sure that the clients know what to look for, and to ensure as well that there were no fears about them going to A&E. So originally people had that concern, should I go to A&E? Will I catch COVID-19 if I go? And we were quite aware of informing them around the sort of areas of A&E that were going to be safe, and to make sure that they didn't just stay at home and not over worry about it, but to access healthcare. We carried on with the bloodborne virus testing for hepatitis A, B, C, And for the HIV, our clinical team, Rochdale and particularly Rochdale to Oldham, again, we're working within services to make sure that we still carried on testing, and also to get healthcare medication out to people. So particularly if people are on hepatitis C treatment, and you'll have seen in the news about cancer and people being worried about the treatment being stopped, we made sure that there was no interruption to treatment, and that was really, really important. We're really on the ball about making sure there was no break in it. Same with HIV. It's important with the medications that there's no break in it. You'll get viral resistance. So again, really important we kept that up. We got out there safe storage boxes, huge risk management approaches, having complex meetings, complex case meetings. We carried on with needle exchange distribution. We again ensured, and it's important because I know where I lived, there was a worry with the bed for a night provision that loads of users all together, that there was going to be needles lying around in certain areas, and we ensured we kept that culture of returning used equipment. And as far as I know, there hasn't been any reports that there's loads of needles lying around anywhere. So that was really important. Again, the record keeping and clear communication with workers that were staying at. So some of our workers were at home working, some were working in the hubs, but we kept that clear communication. As a service, we got all our own digital applications and everything, and software and all the equipment out very, very quickly to keep the service going. Post-pandemic, and this is probably the thing, I've not got, there's 2 slides here, but what we need to continue as a community is to reduce this health inequality that does exist and has existed a long time. The asset-based community development approach is around the individual, and I think it's been around not giving everything to the individual and just giving all the time, but actually getting that individual to make the behavior change for themselves, because it becomes far more effective once they actually make that change. A multidisciplinary approach to understanding that higher risk drinkers need specific extra support, those with multiple disadvantages. Also, we can continue to give them that wraparound support. We know people don't just become addicted and end up addicted just because of the substance, that there's a lot more that's happened in the past, and it's around increased trauma-informed therapeutic approaches and around all services on the people working with people understand and can work with that. The Making Every Adult Matter approach, which is now in Rochdale and has been going on in Oldham for a bit, looks at how we can partnership work and give that extra support and work in innovative and bold ways with the client group. There's a blue light manual approach, and we seem to have forgotten that, but we can do more working with dependent drinkers and engaging them. And from ourselves, our assertive outreach team can certainly do more to work with those drinkers that are resistant to change. An understanding of homelessness and those who struggle to live in accommodation. I think the pandemic has shown that even when people have been housed, they've struggled to stay housed. They've struggled to understand boundaries of being in a property, and that there are rules and regulations. They can't just smoke if they're in a hotel. And I think as well, the local authority looked around giving them vaping pens as well. So there's been some clever stuff being done, but some people just couldn't live in accommodation. For someone that's lived on the streets for say 5 or 6 years, how can they suddenly adapt? And I think that's a challenge. The most marginalised, the most difficult to have the most healthcare problems tend to not get the best healthcare, and that's always been an issue. So that the most marginalised can get the best effective healthcare. And I know we're looking around partnership working for support within this service around wound care, dressings, and we do link up with Heart and do quite a lot anyway. Community to focus on the strength of an addict. So we know addicts and people that use drugs, people that drink alcohol, tend to be a little bit of a subgroup or a marginalised group within that community. But actually what they do is they have quite a lot of strengths. So in the housing project that we work with, we used to look at the strengths, what they could do well, and we use that as an asset within the community. So we were working with people, getting them to do things like litter picking within the estate where they were living, so that the community could actually see that people do change. People may stop using drugs. People do get better from addiction. And I think focusing on a recovery community and lived experience is a really strong thing. Improving support to families, carers of addicts. That's something that can continue, because I think during COVID-19, we can focus on that. Improve mutual aid support. So we know your Alcoholics Anonymous, Narcotics Anonymous have been done online, but self-management recovery training is another model, and that can continue to be improved. We know that conversations in any setting can be an opportunity to elicit discussion about recovery, behaviour change and opportunity. And it can be just a little, on a personal point of view, any conversation can be an opportunity for change. And it can be, for myself walking through Rochdale Town Centre, it can be the fact talking about Naloxone, for helping opiate addiction, and it can be anything, even talking about to someone that's got a dog on the street. How did they get? There's so many opportunities to talk about behaviour change and prepare. I think what we need to do is, as well as in the future, prepare clients for times of unpredictability, and do more workshop work about resiliency, about unpredictability, about a whole range of different issues that they face. Because I think fear, from a place of fear, it can be quite difficult. I know Action Together and Real Change are supporting digital inclusion for all. And I think we all need to look at supporting and helping digital inclusion for all. And also processes of change. Change has been scary for some people. Some people have adapted well to it. And it's around understanding processes of change, and there's so much more that can be done there. And that's the final one, is to look at the addict already has the strengths but might not see it. So that's something we need to think about as well, these strengths that they have. And that brings me to the very, very end. Any questions that we can have?